In the Nigerian health balance,
Mm.
there's what have turned to become like a cliche.
Mm.
That cliche is they say I have malaria and typhoid.
Mm. Yeah. Yes, I've seen it. I mean, I forgot to mention this. They say I have malaria and typhoid. So it's like rice and beans, right? So both of them, you just treat both of them.
Now, because of failed medical laboratory system,
Oh.
it's easy to tell anybody that you have malaria and typhoid. Because my problem with NAFDAC,
Are they equipped
I
to?
don't know about equipment, but I want to speak to their primary name. The primary name of NAFDAC is food and drug.
Yes,
NAFDAC is yet to safeguard us in the area of food.
that's true.
I'm not even adding drug.
No.
They are yet to live up to 40% of safeguarding Nigerians in the area of food and water.
Mm.
I have not delved into drug. So you do not take on what you cannot do.
Yeah.
Tell us how you got here. Tell us how you rose.
Every year, more people die from malaria in Nigeria than any other part in the world. This number is more than the numbers in Mozambique, more than the numbers in Democratic Republic of Congo. In fact, it's more than the numbers in these two countries combined. According to the World Health Organization, they stated that about 27% of the deaths from malaria, the global deaths from malaria, is from Nigeria alone. Now, these numbers, these statistics is not from 10 years ago. No, it's from last year, this year, and possibly maybe from these coming years if nothing is done about it. Now, here's the numbers that nobody is talking about. If you look at malaria, you look at what is going on, you find out that the number of people that are dying from malaria is not because Nigerians cannot cure malaria, no, or we don't have the right medications for malaria. It's because they are not properly tested, they are not properly diagnosed. And this is where the problem is, because the laboratory is supposed to be a place where we go for a test and we get certain results. But we've seen in recent times that is not the case. Here with me is someone who is most qualified to discuss the dangers of misdiagnosing malaria. This person is Dr. Ifeanyi, is the president head of Medical Laboratories Association of Nigeria, and he will be telling us the dangers of misdiagnosing malaria. So if you are in Nigeria, I want you to pay attention to this video. If your loved ones are here, I also want you to share it to them because you will literally be saving their life. Ladies and gentlemen, let us welcome Dr. Ifeanyi. You're welcome, sir.
Yeah, Kelechi, how are you?
I'm fine, sir. I'm doing well. How are you doing?
Well, thank God.
Yeah, so it's a pleasure to have you, in this place. Like I said, nobody is most qualified to discuss about anything related to diagnosis than you, especially when Nigeria or Africa is concerned. And it's a very big privilege to have you here, but I have so many questions. And as you all know, we all have issues with malaria. We deal with malaria almost on a daily basis. So the question I have here is this: if 100 people walk into a lab or different labs, what are their chances of getting the right diagnosis? Maybe they went for malaria test. What are the chances of getting the right result?
Uh,
That they will not just have misdiagnosis of malaria. Yeah.
Thank you very much. The challenge we have with respect to diagnosis in Nigeria is enormous.
Hmm.
And I would rightly describe the issue of misdiagnosis or
Hmm.
wrong diagnosis as a systemic public health challenge in Nigeria.
Oh.
With respect to diagnosis for malaria,
Hmm.
um, several efforts and use of technologies have become available for real-time um, precise diagnosis of malaria. But the challenge is that we have not invested enough. Oh,
Oh.
yes, in these technologies. We are still stuck with rudimentary, permit my word, techniques for the diagnosis of malaria. And even for the very rudimentary techniques for the diagnosis of malaria, it's quite unfortunate that practitioners, a number of them, and charlatans, quite a huge number of them, who dabble into malaria diagnosis, also not attuned to the very traditional rudimentary techniques of malaria diagnosis. So for you to recall that sometime around 2011 or 12 in Abuja here, we had a meeting. Yes, we were invited by development partners to a meeting in Central Business District. Now, what we went there to discuss was task shifting. And part of the task shifting is how to allow patent medicine vendors to do diagnosis for malaria using what we call rapid test kits.
Okay, now I need you to slow down a little bit. When you talk about these vendors, can you break it down so that laymen like us will understand, lay people like us will understand?
Yes. For example, your question is if 100 person
walk
into I'm trying to give you an idea that testing in Nigeria had become too commonplace that it is even done in all manner of places. And that is why, in answering your question before I explain,
yes, sir,
if you take 100 people and do a malaria test for them,
yes, sir,
regrettably, 99.9 of them will come with a report saying they have malaria. And that is the reason why I'm trying to establish the background or the backdrop to why there is huge false reportage of malaria in Nigeria. I agree, malaria is not just preponderant in Nigeria. Malaria is endemic in Nigeria. Nigeria is integral to the tropics. So malaria is endemic in the tropics. So malaria is very much endemic here. And like I was saying before, because of things like tax shifting, where individuals who do not have appropriate training are perhaps, in quote, supported by interventionists, partners that want to help us address our problem to perform malaria testing, you will have the likelihood of false positive reporting. Now, if you go to private hospitals, private medical laboratories, you will also find quacks, charlatans performing this test. So all that add up to the false reportage. Now, again, if you move away to some public health institutions, many of them are inadequately resourced. Yes, including human resource for proper testing for malaria. Testing for malaria is very simple. I'll give you an example. The very elementary means of testing for malaria is to do a microscopy, what we call a microscopy. You make a thin and thick film, and then you stain it appropriately. But in this, as simple as this is,
yes, sir,
the water you use in the staining can alter the outcome. Yes, it is as simple as making a smear, allowing it to dry, and applying the stain. But if the pH of the water you are going to use in decolorization, it will affect the reaction of the cells, because they are living cells, to the stain. And when that happens, you will see a whole lot of artifacts, things that will mimic the structure of malaria parasite in blood cell. And if you are not well trained in microscopy for malaria, you will report it as positive.
To give a false positive.
A false positive. So the issue of training. So microscopy is very elementary, but it is if rightly applied. At the time, there was a time in Nigeria, the World Health Organization dedicated resources to training malaria microscopists. That program is still there, but it's no longer fully supported as before. That is targeted at addressing the issue of false reporting of malaria microscopy. So, but again, the use of rapid test kits had become very common. Virtually everywhere you go, private hospitals, including public hospitals, because they consider microscopy tedious and they consider the turnaround time. Many are adapting rapid test kits where you just take the blood, it can be whole blood, and you apply it to the rapid test kit device, apply the diluent to lyse the specimen, and voila, you have your report. However, Very many of them. Very many of them have issues about positive predictive value. They have issues about sensitivity and specificity. So some of them, for every blood, will show you positive. Some of them, before they show you positive, the patient is dying. And so that is where the place of validation of kits. In the United States, we have Food Drug Administration. But we also do have in the United States what we call Clinical Laboratory Improvement Act. And that act did say that for everything that will be used to test people, it is the duty of the regulators or practitioners of medical laboratory to validate them. Because it can pass tests for production, good manufacturing practice, which is what agencies like Food Drug Administration and our own NAFDAC can cater to. But it will not, it may not pass validation. This validation is what tells us that, oh, for this test, if he says it's malaria, this percentage true that it is malaria. So that's the essence of validation. So most of these RTDs that are used by patent medicine vendors, used by private hospitals, used by some private laboratories, including government-owned laboratories, are not validated. And I can tell you over 97, in fact, more than 98% of the rapid test kits in Nigeria, including that used for malaria, are not validated. So we can't vouch, therefore, for the reports that come using such a device.
So who are the people importing this?
Nigerian traders. Now we
traders, not medical practitioners.
Oh, of course, Nigerian traders. If you go to Idumota, if you go to Bridgehead Market, do you see medical practitioners or medical lab scientists vending these things? You see traders. So a whole lot is in disarray with respect to health consumables in Nigeria. Oh yes, and logistics supply chain is the mainstay of quality health practice, because it is like they say in computer, garbage in, garbage out. So the logistics supply chain is the route that bring resource, consumables, devices into the testing platform. So if it is compromised along that path in any way, you are sure this outcome of its use will be circumspect. So now, there are a whole lot of new technologies that have become available. There are now molecular platforms that you can use to test malaria. Unfortunately, that has not become commonplace in Nigeria. A few centers in Abuja, I'm not sure they are up to 5, has that facility. Fluorescent microscope or molecular platforms for testing malaria.
Is it because it's too expensive?
Cost is a major factor. Now also my friend that is in Switzerland is a Nigerian. He is researching into the use of AI for the diagnosis of malaria. Yes, I'm sure you'll be interested in that. And I can take you there right from here. I don't know whether they are on. Yes, I don't know whether they are around. They are actually, we provided them a free accommodation in AMLSN House. Yes, because of our interest in that research area. So they now have a device, a very small device. Your laptop is bigger than it, maybe the size of the handbag of madam. And all you do is, yes, you make a smear and you put it there. It's computer enabled, and you will see it on your screen. So that way you are eliminating human factor.
Yes, and then cost too.
I have proposed. It's not too exorbitant, because what he has now is pilot products supported by grant. But I had made a proposal that machine and that same machine can be adapted for very many tropical diseases. For instance, the first effort was to use it to do a diagnosis for schistosomiasis, which is the parasite that causes man or woman to pee blood. Yes, or pass blood in stool, depending on the type of parasite. So, and we've done that. It's almost perfect that AI-enabled tool can detect schistosomiasis. It's also very simple. You collect the sample, you filter it, you put it on a slide, and you put it inside, and it tells you how many eggs that is in that place. Yes, so it's that precise. So I discussed with him, and he's adapting that now to other soil-transmitted helminths like hookworm,
Okay.
roundworm, that's ascaris and all those.
Mm.
So, but we're trying to now also adapt it for use in the diagnosis of malaria. And that's where it becomes interesting, because if the Nigerian government, Federal Ministry of Health, can support, not just support, buy into it and make it available in primary healthcare centers, where we may not have well-trained medical laboratory scientists, but we may have technicians. So it becomes easy for the technician to use and detect malaria. So the major problem with malaria, like you said in your intro, is the problem of diagnosis. We have human resource here, some well-trained, some poorly trained, but for diagnosis of malaria, it's simple yet intricate. From all I've said so far.
Can you explain why it is intricate? Because I feel like it shouldn't be intricate. It should be that easy. Just bring your sample and then you get the result. At least that's what we've been getting anyway when we go through.
Yes, but I'll give you an example. Let's say I want to do a microscopy. And I don't have quality stain.
What do you mean by quality?
Yes, the stain we use in this microscopy are all imported. They're not produced locally.
Oh, that's a problem.
Fine. So, for example, any of the Romanowski stain that we want to use, maybe what do you call Leishman for thin film, and the field stain A and B for thick film. These stains are imported. So, if a low-grade stain is supplied to you in your laboratory or is available in the market, so sometimes you can't hold the person performing the test liable. So it's what he has that he's going to work with. So that is part of the intricacy. The shape of the malaria parasite has not changed. It does not change in a good made film. So if it's well made film with good stain, once you put it on light microscope, you will see it.
So if you know, who is responsible for this standardization? Is it SOM?
Not at all. NAFDAC? Not at all. Even though NAFDAC is dabbling into it, it is not within the sphere of their mandate. Recall what I talked about Food and Drug and CLIA in the United States. It is in Nigeria, the Nigerian model of regulation of diagnostics mirrors that of the United States, where, oh yes, for good manufacturing practice, yes, NAFDAC can come to your factory, look at your production protocol, and see what you are bringing out. Whereas once it goes is ready for market and deployment in health facility for diagnosis of humans and the animal, it becomes the mandate of the Medical Lab Science Council of Nigeria to look at it to say this passes validation, and therefore the throughput, the predictive value, the sensitivity, the specificity is within acceptable limits.
Okay, so how do you guys push this? Is it through legislation?
We have a legislation that supports it. But unfortunately, some people want to use the executive fiat to repudiate the provisions of the law. No, for example, I told you that it is traders that are bringing these things. So when you tell them to submit their specimen for, their products for evaluation, they tell you, no, it has not that number.
No. So there should be a clear court agency that is responsible for this.
Yes, so
and then they are empowered by law.
They are empowered by law.
And then if the traders go against it, then the law takes its course.
Well, it is you who who is saying the law takes its course. I'll give you an example of what happened during COVID. During COVID, that was when we optimized that mandate of council. We insisted that because of the controversy around COVID, that all rapid test kits and testing kits that will be used for the detection and diagnosis of COVID must be subjected to validation. It was a big political push. Maybe because the world was at its wit ends. The Nigerian government or politicians or the power brokers did not resist that proposal. So it was accepted and we commenced. And mid-course, a time came when they forced two particular kits almost across the globe, and it was forced down on Nigeria. And they brought two kits from WHO. And we insisted we will evaluate it. You know, there will be political pushback when WHO is making a donation or a recommendation, and we're saying no, we're saying it is not correct. Now, So we subjected it to validation, and let me tell you, it failed validation.
What?
Yes, the report is still available. It failed validation. So when I'm talking about, you are talking about the law taking its course. So where is the place of the law? WHO says you are going to do this. We say, okay, before we use it in country, you don't tell us what happens in our country. You're a global police, health police, but this is our country. And we subject it to our protocol for validation. And it fails validation. So yet it was used.
What? It was used?
Yet it was used. Because you see, the thing about WHO big players is that they are funded. For every funding you get, oh yes, don't think it is charity. There's an interest.
No, it's not.
There's
charity.
a business
It's
interest on seed.
Obviously, there is.
So it's been produced and it must go into the market and the system.
Yeah, but I just think as a
so
nation,
I had to give this. I should keep this to myself.
Yeah.
It's not for public consumption, but it's just to buttress the fact that yes, do we have the law? We do. Yes, do we have facility, infrastructure, technology, and the human resource for validation? Yes, we do. Last month, June, I took a tour of our in vitro diagnostic laboratory in Yaba, Lagos.
Okay.
Yes. And again, they were doing some Sentinel syndicated validation. So we have the human resource, we have the infrastructure for validation. We also have the law supporting that aspect of the functions of the Medical Lab Science Council of Nigeria. But it is being contested. Oh, NAFDAC wants to take it. And my problem with NAFDAC,
are they equipped to?
I don't know about equipment, but I want to speak to their primary name. The primary name of NAFDAC is food and drug.
Yes.
NAFDAC is yet to safeguard us in the area of food.
That's true.
I'm not even adding drug. No. They are yet to live up to 40% of safeguarding Nigerians in the area of food and water. I have not delved into drug. So you do not take on what you cannot do.
Yeah.
It is not, like I just told you, what is their mandate? Oh, anything you produce that will go to the the health sector, that will be consumed in the area of production. They will look at what we call good manufacturing practice. They will look at what we call, since it's a laboratory based, good laboratory practice for production, for safety of production.
Yes.
That will be post-market. But can I use this to determine if somebody is pregnant? It has gone out of this sphere of NAFDAC regulation. So it has got to deal with a regulator that is in situ in the health sphere. So the Medical Lab Science Council is integral to the health system because it regulates the practitioners, it regulates the practice, it regulates the facility. So the validation sits squarely in their mandate. So it's not about absence of law. No, it is not. It is about the political maneuver in Nigeria, which is very unhealthy. Let me give you an example. At a time, we pushed and pushed and pushed. The Custom General, what do you call it? Yes, Controller General of Customs. DICO was the CG of Custom. And the man saw reason with us and pushed and got an approval for Medical Lab Science Council of Nigeria to have booths in the port. So if you bring the junk, we dictate it in the port. And then we ask you to take it back.
Exactly.
Do you know it was contested and stood down till today?
By saying NAFDAC?
Not NAFDAC per se, other political interest group. Oh, yes. Some people felt the Medical Lab were becoming too prominent. Powerful. Not too prominent. Leave power. Power has been given by the act of the parliament, but too prominent for their comfort. But it's not about being prominent. It's about protecting and safeguarding the health of Nigeria. It's about what we call patient safety. And anytime you discuss patient safety, the safety begins in diagnosis. Because if I say somebody has cancer, and that individual do not have cancer, that individual will be subjected to therapy that will kill the individual. So safety starts with diagnosis. Oh, we're discussing malaria. I say you don't have malaria and you have malaria. And that is also a case here. For example, most of the places they use rapid test kits that are not validated, some of them that in a bid to achieve what we call specificity,
Okay.
which is that when it says it is malaria, it should be malaria at least above 85 or 90% of the time. Now, in a bid to achieve specificity, they lose sensitivity. So you can have malaria parasite, but it must exceed a very high threshold,
Okay.
not a minimum threshold for that rapid test kit to
Okay.
detect it. So these are the issues we have with the malaria diagnosis in Nigeria. But above all is the case of charlatans. This morning on my way here, an artisan came to fix something in our secretariat.
Okay.
And he said, they told him, he saw the name of the place. He said, this picture looks like the eye opener. And they say, yes, this is the eye opener's office. So he now said that he would like to talk to me. So they put him on call to me. This individual has done his genotype somewhere. For years, he had known that his genotype is AA.
Yeah.
Within Abuja here, he walked into a lab and they repeated the same genotype. And they now told him he's AS. So he moves to another one and they tell him he's AA. So he is now confused.
Yes.
I had to admonish him.
Okay.
Now, sometimes I remember when we were saying get a second opinion.
Yeah,
this individual has a third opinion.
Yes. And he still doesn't know. So, but what should this person do in this scenario now? Because I know someone in this same mess.
Well, what the person should do is to go to another renowned laboratory. And we can do what we call interlab comparison or blind sampling.
Okay.
So you get the same sample, you aliquot the same sample, send it to two different places. And see what will come. But before you send to those places, you should also be sure it's a place that is duly registered, that participates in external quality assurance program. So the problem is not laboratories. It is not even how magnificent the building or the premises looks like. It is the who is behind the mask. Who is behind the mask. So why I had to digress to genotype is to also bring to fore the fact that we have people who should not be in the medical laboratory testing business.
So how do we detect these people?
Yes, it's a work in progress, and for me, it's a concern because if we allow the Medical Lab Science Council of Nigeria to optimize its mandate, we will drastically reduce the players who shouldn't be in the sector. And how do we do that? I've been pushing the new registrar, new registrar, to buy into the idea of if you do a test and you give me the paper, your footprint is on the test. Just like if a lawyer gives you a document,
that MBA,
his footprint is on that. So once we have an issue with your report, it flags you. We do not need to do any forensics. Your seal, like lawyer, is on it.
Digitize it, yes. Okay.
So that is one way of dealing with them. And then also the person who wants to patronize laboratories should look out for fundamental things, the telltale sign that this place is not registered. If you walk into a laboratory and in that laboratory you can't see conspicuously displayed the CAC registration of that laboratory, and you can't see conspicuously displayed the Medical Laboratory Science Council of Nigeria certificate of registration.
This is the main thing, because anybody can just go to Corporate Affairs Commission and get a CAC.
So if you don't see that, and you also can't see the current practice license of the practitioner in that facility, it's enough for you to stage a workout. Don't engage them.
And then maybe report them too.
Yes, you can go ahead to report them to us. But you see, reports are better when predicated on service failure.
Okay.
So the person has a
Yeah.
prima facie
Yeah.
matter to answer to. Because if you walk into my facility and say, this place is a fake place, and I ask you why is the place fake, you say you didn't see this, probably the person has it under his desk. So it won't fly. But if you come, say this place, I question what they have done. This is what I have against them. I took up their service, and this is how it turned out. It turned out wrongly. So that gives you the what do you call the locus to say that this is a fake place, or to flag the place, or to report the place.
Okay, back to malaria. What are the dangers of misdiagnosing malaria for even normal people like us and even the pregnant woman?
You see, malaria, as simple as people take it, is responsible for a very high number of both infant and maternal mortality. That means it accounts for high number, in hundreds of thousands
In Nigeria.
in Nigeria, of infants under 5 and of mothers, including pregnant women, as you've mentioned. The disability associated loss in years due to malaria disease in Nigeria is also very high. The sequelae of malaria, which includes things like hepatosplenomegaly, inflammation of the spleen.
Okay. Can you calm down?
That I'm already going down.
Okay.
Inflammation of the spleen and the liver as a result of malaria disease burden is high. So because it's high, it's capable of leading to death. And it had led to the death of many. Yes. And you think malaria is small. When you have cerebral malaria, it can make you behave like a mad person. And of course, in very many instances, it leads to ultimately death. So malaria is simple because it is endemic, we trivialize it, but it's a killer disease. Malaria is a killer disease. So the death burden is high, the disease burden is high in Nigeria. And when you now, of course, these things are high in Nigeria because we're playing with diagnosis. Oh yes, morbidity, mortality rates for malaria is high in Nigeria because we play with the diagnosis. How? So I am feeling, once there's a slightest sign of malaise and discomfort, people are walking across the road over the counter to take anti-malaria.
That's true.
I recall what I said happened in 2014.
Yeah.
The idea was for them to produce a jingle, and they did produce the jingle. If your body they do you somehow, if you be malaria, make you go patent medicine store, go take ACTS. Oh, that if you go back in time, you will see these jingles. They were everywhere. I had to lead a revolt for them to now say, if your body they do you somehow, do a test to check if it's malaria. That modification took more than 10 years for us to achieve.
What? And it has saved a lot of lives.
That modification. So that is to situate properly the place of testing in the containment and control and management of malaria. So we have issues with diagnosis. Wrong diagnosis is why you will progress to hepatosplenomegaly. Wrong diagnosis, because you have malaria, the thing you don't have. Wrong diagnosis is what will make you end up with cerebral malaria. Oh, you have malaria because they are using rapid test kit that is low in sensitivity, or of course low in sensitivity. You will not be told you have malaria, and it will progress to cerebral malaria and the associated challenges or death. Or you, because each time you just feel unease with yourself, you are gulping anti-malaria. So you get to a point where you help to spread drug resistance. Just the way we have in antibiotics, we have anti-malaria drug resistance. And anti-malaria drug resistance is quite high in Nigeria. Unfortunately, we do not have the support system for us to continue to do a study to determine drugs that we're using that had become resistant. It can be done. We have done some in Abuja before, but the funding is not there. And the one we did in Abuja before was done as an academic exercise of an individual seeking to earn a master's degree. It is something that should be a routine process.
Yes.
That say every 6 months, we will take samples within the FCT, take samples within any state capital, go to rural area and conduct a susceptibility testing for anti-malaria. To determine the ones that have developed resistance, because I don't have a very bad attitude to drug. Just walk over, take and drink.
Yeah.
So because of that, that again could lead to cases of wrong diagnosis. So wrong diagnosis, the impact in the management of malaria is very, very, like in any other thing, is high. And the consequence most times is deformation and death.
Oh. Wow.
Yeah, because now, if a child has a poorly managed cerebral malaria, it might ultimately affect the meninges and affect the child's ability, cognitive abilities. It can go beyond that to affect the ear and hearing of such child.
Sir, you've mentioned cerebral malaria
Yes.
about 5 times now.
Yes.
What's the difference between cerebral malaria and normal malaria?
Cerebral, we say malaria has become cerebral if it's found itself beyond the bloodstream and has entered into the CNS, the central nervous system, and migrates to the meninges of the brain. So when that happens, then, like I told you, for some people, you would think that they had become lunatic. They are not mad people. They are not. For some people, it will lead to, of course, I talk about dementia, but it can lead to delirium. They lose consciousness. They become confused and go into a coma and can die.
Wow. Okay, that's great. Now, let's look at this twin brother of malaria called typhoid. So we've seen people, they said, oh, I was taking malaria medication, but it turned out to be typhoid. What is the consequence of taking the wrong medication for another? You have malaria, you're taking typhoid, and then you have typhoid, you're taking malaria. What's the consequence?
In the Nigerian health balance, there's what have turned to become like a cliche. That cliche is they say I have malaria and typhoid.
Yeah. Yes, I've seen it. I forgot to mention this. They say I have malaria and typhoid. So it's like rice and beans, right? So both of them, you just treat both of them.
Now, because of failed medical laboratory system, it's easy to tell anybody that you have malaria and typhoid, because if you know what you are doing and if you have the resources and infrastructure, you should succinctly say what is wrong with the patient, because malaria is a parasitic disease. Typhoid is a bacterial disease. Malaria is as a result of mosquito, the vector that transmits malaria, biting you, putting some stage of the parasite in the system, and it develops. Typhoid is a food and water-borne disease. Consumption of contaminated food and water. As when we say food and water, we will talk about things like dairy products, talk about things like poultry products, including your eggs, the chicken itself, vegetables of all kinds, and other forms of food that are subjected to manipulation without cooking. The likelihood of picking up typhoid from them are quite high. Now, so back to the challenge we have. Okay, for instance, they tell you, and let me tell you, more often than not, it is actually the malaria that the individual has. But you say, they say I had malaria, but now later it turned out to typhoid. How did they come to later it turned out to typhoid? Now, the issue again takes us to the diagnosis.
Yeah.
I had earlier talked about diagnosis of malaria. So let me talk more about the diagnosis of typhoid fever. Now, it is more difficult to make a diagnosis of typhoid. Very difficult and cost intensive. Because for you to determine that an individual has typhoid, time is of essence.
That's true.
Within the first 7 days of exposure, and the person has ample clinical manifestation, foremost among them is that of temperature.
Okay, that's
When I was a student,
okay.
they taught us something that has disappeared in common medical parlance, what we call PUO, pyrexia of unknown origin.
Okay, can you explain what that is?
I've explained PUO, pyrexia. Now, pyrexia simply means increase in body temperature.
Oh, okay.
Every person, human being, should have a temperature not exceeding 37 degrees.
Okay.
For some people, it can be 36. For some people, it can be 36.5, but it shouldn't exceed 37 degrees. And so when you have a temperature exceeding 37, sometimes progressing to 39 and 40, and we are sure you do not have malaria, the first thing to now check is typhoid, and if you are a veterinarian or you're an animal header, brucella.
Oh.
Now, but let's limit to typhoid. So within that first 1 week, at the peak of pyrexia, peak of temperature, 39, 40, if you're able to do a blood culture, you will isolate the bacteria Salmonella typhi from the blood culture. Now, the point need to be made clearly, therefore, that when your temperature is 36 degrees and 37, and somebody is struggling to isolate typhoid from your blood culture, check the person is a cheat. Oh, yes. I just explained how it works.
Yeah.
Because at that peak of temperature is when the bacteria is shaded to the bloodstream.
Oh.
So you're able to pick it then. After 1 week, your likelihood of recovering the bacteria from blood culture becomes diminished. Because it becomes diminished. And when it becomes diminished, you will now rely on stool cultures. Within the second to the third week, you rely on stool culture. Now, so you can see the place of timing. But let me speak to the real issue.
Okay.
A normal place that will do blood culture for you properly in FCT may not charge you less than 40 or 50,000.
Oh, okay.
How many of us can afford a blood culture? Most times, too, still on blood culture, people would have had antibiotics. And so if they have had antibiotics and you're struggling to do a blood culture, you are embarking on an effort, most likely in futility. You see how intricate it is.
Yeah.
So most people can benefit from blood culture because of our attitude to antibiotics, for which even clinicians, or call them physicians, are complicit. The average Nigeria can walk over and buy any form of antibiotics. Of course, most times, while you are yet speaking to a clinician or a physician, he's already given you a prescription of antibiotics. So by the time we talk about blood culture, you find out that we have already breached the time and conditions precedent for it to support the diagnosis of typhoid in Nigeria. Now, the issue again is on stool culture, including private and public facilities. For you to do a stool culture rightly, following a standard bacteriological practice, the protocol, to arrive at this individual has typhoid or do not have typhoid, that individual will again be paying you between 30 and not less than 40,000. Because the materials are quite costly and many times are not locally produced. So most times are not even available in Nigeria. And what I'm saying applies even to the one you call government hospital. That's the challenge we have.
It's a big challenge.
It's a big challenge. So because they say Nigeria is a low income country. There's what we call LIMICs, low and medium income countries.
Okay.
So we put Nigeria there, where resource challenged. But sometimes I beg to disagree. A country in the continent that in its airport we have the highest number of private jet
It's
hangars.
priorities.
It is corruption.
I will always say this: we have a spending problem.
Yes.
Yeah, we have a spending problem.
So-
We have a priority problem where we prioritize. You see, I will always say this, I will die on this hill, that we subsidize the wrong things in this country. We subsidize Hajj, we subsidize pilgrimage, people going to Jerusalem, people going to Mecca. And then we look at these things, this problem we have, and yet they don't have any form of subsidy. And yet it is life-threatening. I think something is very, very wrong and it should be changed. If you ask me, why do we continue to subsidize things that shouldn't be subsidized in the first place?
Well, it's priorities, political priority.
Yeah,
It's
I
political
see.
priority where we have a challenge. For example, the person telling you to fry akara. The person telling you to fry akara has almost all her life been a senator.
Yeah, that's
We
true.
have not seen a restaurant she operated.
Mhm.
So, and we don't have akara factory. So, if you're asking me to do, it's political priority. It's like in the health sector, like in the works. The road that leads from Abakaliki to Calabar is death trap. But I'm doing what do they call it? Lagos Calabar transatlantic
Yeah,
route
so we can see the ocean.
is the priority.
We
But-
can't but the
But
ocean
if
view-
I do the road from Abakaliki to Calabar,
Yeah.
all the plantain, cassava, yam produced in
Yeah.
that axis will hit the market and will speak to the issue of food security and can build our capacity to export agricultural
That's
produce.
true. That's true.
So it's about political priority.
yeah,
So we're back to what we're saying. So in the issue of diagnosis
yeah.
for typhoid, again, we have challenges with resource
Mm,
and human resource capabilities.
mm.
Now, the commonest thing you see everywhere in Nigeria is a typhoid diagnosis based on what is called VIDA test.
Wow.
VIDA test is a simple agglutination test. It used to be of value.
Mm.
I will still insist it is of value today. But
Okay.
this is the challenge we have with it.
Okay.
One is that poor quality VIDA reagents are about 98% of the ones in Nigeria.
Yes, and
Poor
most of our
quality.
tests are typhoid tests. are
Poor
VIDA
quality.
tests, yeah.
So poor quality. And so when you use them, virtually all of them have a sensitivity around 99.9%. So once you drop it, you will see reaction.
Then it should be phased out.
It's not-
Considering-
it's-
considering how old it is. I heard it's over 130 years ago.
The problem with the technology is not the age.
Okay.
For example, if you bring good quality VIDA kits into Nigeria,
Mm.
and there are a few of them, that's what I told you, very few of them. In fact, if you want to buy that one, the money for buying one pack, let me give you an example. If the good quality is 40,000 per pack of a kit, and you can find the one you buy for 6,500, as a Nigerian who is not ethical,
Yeah.
which one are they likely to buy? The 6,500.
Obviously.
And that's the problem we have. So that's just one of the problems with the VIDA test. The VIDA test is not designed for you to use it one-off to determine or make a diagnosis of typhoid.
Typhoid. Okay.
It is designed in a manner that you must use it to demonstrate a 2 to 3-fold theta rise before you can now say this individual has typhoid. I give you an example.
Okay.
You come the first day with fever
Mm.
and we'll take your sample. and we do a titration. Meanwhile, that's another part. Most of the people who do vidal test do not know anything about vidal titration, from which you will determine the titer. So they just do a slide testing, what we call slide testing, and they are reporting that you have typhoid. So if we do the first one, I will get a titer. Say, for example, the first day you come, the titer is 1 in 40. I tell you, well, from what we have done, we will need to repeat. So assuming in a week or a fortnight, and you are yet not okay, and you return, and we repeat. Remember, I told you first week, second week, third week, and you return, and we repeat it, and it is now in the neighborhood of, say, 1 in 80. It is showing a rise, but it is not a 2 to 3 fold rise. If you come again and we repeat it, same use, same blood sample, and we repeat the same fresh sample from you, and we find now that it is around 1 in 160 or 1 in 320, we can now, you see, over time we have demonstrated a fold, 2-fold, 3-fold rise in the titer, in the titration, in the quantification of the antibodies we're detecting.
But don't you think it will take time?
You see, this is the
Like
protocol. No, but this is the protocol.
Okay.
That is the protocol, because for us to even begin to apply with that, you would have not been suitable for blood culture, or would have done a blood culture and we didn't detect. For us to start applying with that, you would have done a stool culture and we didn't detect. But I've discovered that what Nigerian physicians do today is that when you take a vidal test to them, some will tell you, go and do stool culture. Very good. Very good. Now, some also will tell you that you can only do stool culture when the vidal is indicative. But that's not true.
Okay.
Why did I say that it is not true to do a stool culture when relying on the vidal test to indicate? I told you 2 to 3 weeks, the patient sheds it in stool. So by that time, antibody is really fully formed and becomes circulated, because the vidal test is not an antigen-based test. You are detecting an antibody. But this is what is happening recently, and by a Nigerian, and it is fascinating. There's a company in Nigeria, a Nigerian company that has commenced the production of an antigen-based rapid test device for the detection of typhoidal disease.
That's a good one.
Yes.
Yeah, that's a good. I always feel and advocate that technology should be domesticated.
Yes. So
especially when it comes to health.
They have reached me that I should come take a tour of their factory to see what they are doing. And then they are subjecting their product to AMLSN validation. So with that, for me, there seemed to be light at the end of the tunnel for us in Nigeria.
That's good.
Because they have both the antigen-based text platform for typhoid, and they also have the immunoglobulin, the antibody base that really would detect an IgG. So if you're able to detect IgG, it means it is a specific antibody to typhoid. So these two are emerging diagnostic intervention that apparently are rapid, but again, it's not found its place across the country. Yeah. So
now we've had instances where a doctor will just touch your neck,
that one,
and then they will tell you you have typhoid, you have malaria, after maybe explaining some symptoms. So can we categorically say that doctors are not qualified to diagnose this kind of ailment?
Well, this is diagnosis for all and every disease condition. Diagnosis is in two flanks. There's provisional diagnosis, as the name implies, provisional. You know, when some of us went to school and were looking for job, they'll say they've given you provisional admission.
Yes. Yeah.
It is provisional. Or they've given you provisional appointment.
Yeah.
It is subject to confirmation.
Exactly.
Now, the same for diagnosis for every disease. So what is a physician trained to do?
Yeah.
Make a provisional diagnosis. Listen to you, do some physical examination, take down the sign he's able to see, sign you must see. Take down symptoms. He will never see symptom. It is you. In fact, if I stand up now, I feel like falling. It's only you who can tell me that.
Yeah.
As a physician, I can't see it.
That's true.
By the time I'm seeing it, you are down.
Absolutely.
So it takes all that together and falls back to knowledge in the subject area. And so it looks like this man has typhoid. And that's what led to what I used before. In a normal balance, that physician will write PUO.
Meaning?
Paresia for unknown origin. I've looked at this person, he has blood temperature, all this. So now that is provisional. So the physician can make a provisional diagnosis.
Okay.
But provisional diagnosis, more often than not, is not sufficient for you to progress to start treating. So you now have another flank of diagnosis, which remains the duty of the medical laboratory scientist, and which is you can't divorce from them. Now, because you can't divorce evidence, you can't divorce evidence. So if you have this provisional diagnosis, you are now sent to the laboratory for another type of diagnosis, for the laboratory to conduct tests and provide data that confirms. So laboratory diagnosis is taken for, as a matter of course, confirmatory diagnosis. So if it is a disease outbreak, it is the laboratory that will confirm it. Even if I see 100 people die here, I cannot say it is cholera until I take their specimen and I go to the laboratory and I confirm it. So laboratory diagnosis is confirmatory. Provisional diagnosis, no, it is not confirmatory. So that's the difference. So, but for you to now treat a patient, manage a patient, prevent disease, intervene in an outbreak, it must be taken together. So that's it.
Okay, I thank you very much for this. I don't feel like we've given diagnostics the attention it deserves, not just as a government, even as individuals, because many times people just, when they feel any symptoms, they say it's malaria and they get all the counter medication and all. But can you strongly say that it is linked to poverty or awareness or both?
It's failed systems. It has nothing to do with poverty.
Okay.
It is failed systems. Okay. Is it poverty that makes somebody drive one way?
No.
You see a lawyer, a doctor, a professor turn the steering, face the one way. Is it poverty?
Sometimes you see government officials.
You know, it is not sometimes. It is the stock in trade of politicians and power and fine. So is it poverty that leads to that?
No.
Anybody who walks over to buy drugs over the counter is driving against the traffic. That is not. That is what it is. You are driving against the traffic.
Okay, that's a good way to look at it.
So it has nothing to do with poverty. Because the truth is that diagnostics save cost. Medical laboratory diagnosis saves cost. I don't know whether it's malaria. I don't know whether it's kidney failure. We now find out that you have none of them. Your cost is saved. They say the way at the piece, it must be diabetes. And we'll just check and we'll discover that what you have is UTI, not diabetes. you are saved.
Mm.
Resources are saved.
Yeah, that's true.
So when people make up their mind to drive against traffic, it is
Mm.
not because they are not burning fuel. They are burning fuel, but they are driving the wrong way. So it is systemic.
Mm.
There are smaller countries, both in terms of size and resource, where nobody, and that person doesn't even need to be a pharmacist, nobody manning a drug post, whether as pharmacy shop or whatever you call it. Of course, the word patent medicine vendor is only common in Nigeria. You don't see it any other place. Yes. So it's a Nigerian creation. Now, nobody goes to those countries I cited to say, give me ofloxacin over the counter. Nobody will listen to you. In fact, they may even report you to police. So it's not a matter of poverty, it is systemic failure.
Oh.
Yes.
Okay. All right. You've explained it, but let's look at the minimum wage now. I think, how much is it? That should be 70,000. So what should we do to make proper diagnostics accessible to people on the minimum wage so they can afford it? Accessible and affordable to people on the minimum wage.
We created in Nigeria first a National Health Insurance Commission.
Okay, yeah.
If you go to the very first enabling law that set up that commission, which had become serially amended to what we have today, the National Health Insurance Authority.
Okay.
And of course, their product is the health insurance scheme.
Okay. That's the one I know.
Yes. Their product, what
Okay.
they have, whether when it was commissioned and now
like
that it's authority.
No,
it did not. It was commissioned. They kept amending and it became authority. What is what we have today. But what the service they provide is National Health Insurance.
Scheme. Okay.
Now, that is where our undoing and undoing of the low income earners was sealed. If you go to the NHS in the United Kingdom,
okay,
which is likely where we borrowed this lofty, wonderful program or intervention, there is nothing saying that if I come to your hospital, it becomes a global hub where if I come there, it is there I must do my test. It is there I must collect my drug. It is there I must do my eye.
They just want to keep all the money.
They call it global capitation. It is that global capitation that I call global corruption.
It is.
That had robbed Nigerians of the benefit of the national health insurance system. In other place, this your space is enough for a GP. What do the GP do? The GP who is enrolled as a primary healthcare provider takes consultation. And when he is done, he could give you a prescription or laboratory requests or request for x-ray, whatever. You will take it to the fee for service provider, which can, in this case, can be a pharmacy shop. So you go with the prescription. They give you your drugs catered for under the scheme. Or you walk to the laboratory downstairs, who is also part of the NHS, and you have your test as prescribed by the GP performed. So you can now go for post-evaluation, either post-result evaluation or post-treatment evaluation, further consultation with the GP. Do you see how it's spread? So if we have that kind of system in Nigeria, the person who earns 70,000, who has been contributing into the pool, he might be because the contribution is a function of what you earn. So he contributes pursuant to his 70,000 naira minimum wage, for example, 700 naira every month. But when he's sick, he's able to go to any lab of his choice and get the test done under the health insurance scheme. Now, not everything about the health insurance, National Health Insurance Authority is bad, but this is a fundamental flaw why it is difficult for poor people to benefit. Well, that is a fundamental flaw that has continued to sustain out-of-pocket spending, that global capitation. Now, they made it look attractive. You just come everything in one place.
Like in
No,
one shop.
we want to have it in one shop. Monopoly and manipulation
Yes,
will become commonplace.
Yeah.
Now, what is it that can be done? Part of what they did, you have just talked about minimum wage of 70.
Yes, sir.
That is in the formal sector.
Yeah.
Formal sector in Nigeria is less than 5% of the Nigerian population.
That's true.
So 95% are not part of those that 70,000 minimum wage cater to.
There are people,
now,
some people earn as low as 30.
Yeah, so
30.
that takes us to why I said the NHI has a good component, even though I've pointed it a major flaw, and I needed to tie that to access and affordability for low-income earners. Now, they have what they call community and faith-based insurance scheme, where a church, say for example, the Catholic Church, with very massive number and followership, maybe I'm selling them business. And I also do know, yes, that some Catholic facilities, maybe dioceses and other, like I know in the Southeast, they have one or two now that is metamorphosing into full-fledged university. For example, if you go to Nsukka, they have the Bishop Shanahan Hospital, which is a Catholic-based hospital. Imagine a situation where the entire diocese in Nsukka Diocese of the Catholic Church decides to say we now have a faith-based health insurance scheme. Every member that comes to church on Sunday just drop ₦1.
That's a good idea if you ask me.
And so they tick it for you the way they tick. You know, I used to be a Catholic. They used to tick one card they call AMC. So, and it has a system. The resource that they will mobilize will provide PET scan for those who have cancer.
Wow.
Oh, yes. Just imagine it.
So even that expensive kind of...
Yes. It will eventually become available because the insurance system is a pool of resources. I've been contributing as a public servant. I've never gone to any hospital for one day to use that one I'm contributing.
That's true.
So it continues to be in the pool for those who have need of it.
Yeah. But what do you think is responsible for that? Because I've never used it. Because, okay, there's
what I'm taught, which we call divine health. Some of us are living in divine health. That is a faith-based conviction anyway. Then lifestyle, for those who are not faith conscious, lifestyle is like a vaccine. It differs disease from you. It differs disease or sickness. So I just gave that idea. I do know that some years ago, some states like Kwara, a few other states, I don't know of any state in Southeast, also attempted this community-based insurance so that they can harness the informal sector. So having said that, I still think that if we do the right thing, we will have enough resources to support access, availability, and universal coverage.
Right. So, but I also feel there's a problem too when you look at the quality of medications for people under the NHIS. You know, people complain that when they go there, you know, the kind of medications they see or receive
low
are
quality.
Not low quality. So, don't you think it will also affect testing to diagnostics?
You are forcing me to leak a secret. I know a facility somewhere along the Port Road.
Okay. In Abuja.
In Abuja. And that's the in. Those are the ins of global capitation and why I'm against global capitation. Because the patient is condemned to take all the services from one given facility. He has no option of choice. Choice is fundamental, inalienable right of service uptaker.
That's true.
Now, you come, you say, it is Emeka Hospital that is my primary healthcare provider. Global capitation for that matter. So if I go there, I must do my test there, I must take my drug there, I must take everything there. So Emeka is in Emeka Hospital to make profit.
Yeah, it's a business.
And now let me also shock you, part of the problem we have in Nigeria. Who regulates hospitals in Nigeria?
The Ministry of Health.
A story for another day.
Wait. Because we can look at telecommunications and we look at SEC, look at CBN and the banks.
So who regulates hospitals?
Okay. I just assume it's the Ministry of Health. But how come? Okay, that's a big question. I just realized it now that nobody's regulating them.
Well, according to the Constitution of the Federal Republic of Nigeria, health is in concurrent list. So expectedly, facilities, health hospitals, for instance, particularly,
Okay.
and by extension, other health facilities ought to be monitored, registered, and monitored by the State Ministry of Health.
Okay.
But that's not the.
So that means I'm
that's
right
not
then.
that's not the regulation. That's not the regulation I'm speaking to.
Okay.
But who regulates what goes on
Yeah, inside the hospital.
day to day
Mm.
in the hospital? Nobody. So that is why I have this drug from Pakistan. I have this one from China. I have this one from India. I have this one from England.
Mm.
And that for England is 20,000.
Mm.
And that from Pakistan is
Yeah,
2,000.
yeah.
And that from China is 1,002.
Mm.
And I'm in global capitation. Which one am I likely to buy?
1,000.
1,002. So you come, I give you 1,002.
Mm. Mm.
So I make so
Yeah.
the point is,
Yeah.
for me, I support the original concept
Mm.
of the National Health Insurance Scheme, where you unbundle the service, where you register fee for service provider.
Mm.
So you can take the prescription, go to a pharmacy shop, and the pharmacy shows you
Yeah.
this is 2,000,
Yeah.
this is 1,500,
Mm.
this is 1,000. What is the difference? This is made in China. This is Paki. This is from England.
Mm.
The bioavailability of this one from England, or it is already a renowned brand. So the likelihood of it being faked is less.
Mm.
Well, your money covers that of 1,500.
Mm.
If you want this one, take it and pay 500.
Is it out of place to ask the private sector,
Yes.
private lab owners,
Yeah.
to be part of the NHIS?
I have people who, that's why I told you the old concept.
Mm.
I have labs that are registered. I have pharmacy shops that are
Register with
registered.
NHIS.
In fact, if you go around, if people that have stayed in a premises for a long time, you will see the sticker on the wall. But are they getting anybody? No. Global capitation has locked all those under the scheme
Oh.
into a condemned facility or provider.
Mm. I get it now. And can we also say this global capitation
yeah.
is also responsible for what happened in
I was telling you about lab.
Yes.
And so that lab along, that hospital, not lab, hospital,
Along
full-fledged
Airport Road.
hospital,
along Airport Road.
along Airport Road,
Okay.
do not have facility for some of the testing.
Mm.
And most of the testing was happening in the waste bin by the doctor's table.
Don't you guys have the power to shut it down?
So you come,
I just asked a question.
he
If you
sees
guys
you,
have the power to shut
he
it down.
requires the test, they take the sample, and the sample ends
There.
on the waste bin.
But do you guys have the power to shut such places down?
We don't regulate them. It's not our lab. It's not a lab. It's a hospital. We
Oh.
only regulate the labs in the hospital. And a few times we have barged into labs in hospital.
Wow.
Yeah, we have ended up either in court or the ministry telling us to halt inspection.
That you don't have the power.
No, not power. We have to halt.
Oh.
I remember one inspection sometime 2016
Mm.
in Lagos.
Oh.
Our men were in the field.
Mm.
Untouchable big hospitals were being inspected, and the atrocities were being uncovered, and we got a call to halt inspection in Lagos.
Call from above.
To halt inspection in Lagos. So you find out that for us, the problem of access and affordability again is systemic. If we put systems in place, like what we discussed about National Health Authority, if we expand the coverage for the informal sector, using the example I painted about
Yeah.
Catholic Church,
Yeah.
resources will abound.
Yes, that's true.
So there will be affordability and there will be access.
That's true. Okay, I always don't believe that people should go into the health sector for the sole aim of making money. I don't believe that. But there's something I have noticed that when you go to many of these hospitals, or let's say lab now, people like you, that's your sector, and you want a malaria test, there's every likelihood you come up with typhoid, or you come out with typhoid. Now, they are the one running the test, they are the one selling the medications, they are the one with the hospital facility. Are you saying because typhoid is more expensive to diagnose than malaria, and the medications for typhoid is more expensive than malaria, are you saying that's is an added incentive to ensure that almost everyone comes out with typhoid?
Well, we have forward people everywhere. Forwardness is not sector dependent.
That's true.
Now, while I will not dismiss what you have said,
Okay.
in the Nigerian context, I don't know how to say, use the word profit, whether it is appropriate here, but gain, and money. Yes, I think it's money. Quest for money is the number one priority for those who set up facilities. Unfortunately, by the ethos of healthcare provision, whether you're a physician or any other healthcare professional, for us, it is humanity and
First.
service. And service. Meaning, what is the cost for humanity? What is the cost of you rendering service for the sake of humanity? If it is possible, it should be at no cost. But because of bad orientation, which is, I must make the most of where I find myself. The most you make is not supposed to be monetary most.
Yes.
It is about impact.
Yes.
So, but we have a mentality that is insane.
Absolutely.
Measure of contribution or impact is about how much of money you control. So that is why you would find, because like in the place where I come from, they say life has no money worth. So
That's
no
true.
matter what they tell you to
That's
pay
true.
to be alive and healthy, you will pay. So people who know this now are taking an undue
They're
advantage.
abusing it.
That is, you have talked about malaria drug. Let me take you to another place.
Okay.
When I was growing up, the word cesarean section, I couldn't pronounce it very well because it was not common. In fact, it was unheard.
That's true.
In fact, women will abuse you when they gather in church or society. This one that cannot push child. You are not a woman enough. You can't push child. Okay. That was where we're coming from. Today, almost out of every 100 pregnancies, about 70 will be CS.
That's true.
Why? Once they cut you, 500,000. So that's the problem. It is not that.
There's even a case of.
And I hope you know that in Israel, there's an intervention to facilitate safe delivery, but not cesarean section.
You see?
There are technologies. Yes, but here, she gave birth by CS. The husband would have parted with 1.5, 2 million, depending on the facility.
That's true.
So that is the place of greed over humanity.
Yeah, that's true. I've heard of this hospital. I don't want to mention names, where the medical director asked some of the nurses, I say, wait, we don't have anybody here We don't have any patients. No. Give them a bed. Give them a bed. So even things that ailments that doesn't require the person to spend
The
the night
night.
here, they just give them because it's more expensive to have that. You see, there's a lot of things to onboarding, but we are beginning to round up now. If someone want to do what you do, want to end up like you, what is the career path? What should the person study in secondary school? What should the person study in university to end up a scientist like you?
Well, the medical laboratory science profession is the second leading professions in the health sector globally.
Oh.
And in some studies that were done in sometime 2020, 2022 in the United States, it was also among the leading professions with very, very bright and positive career options. But I will say the same for Nigeria. For me, I'm fulfilled as a medical laboratory scientist.
That's true.
Even though I used to tell people if I come another time, I won't be a medical lab scientist.
Okay.
Yeah,
I'll come to that later.
because I would not.
No, but why? Let me come to
I
it
wouldn't
now.
want to be a medical.
What's
lab
your
scientist.
reason?
Now, particularly in Nigeria, let me give you a very simple reason. One of my boys used to work in a teaching hospital in Nigeria.
Okay.
And before then, his salary was 280,000. He struggles and manages to hit island. And he's earning, as of today, $6,000 per month.
That's true. That's true. I know where you're headed.
So why would I encourage my son to
Practice
get a good grade in English, maths, physics, chemistry, biology, to become a medical laboratory scientist? And when he leaves school, he will be roaming the street for employment in Nigeria because the system has refused to employ medical laboratory scientists. You heard what I said, that is among the first leading professions globally.
That's true.
During COVID, the world came out of COVID pandemic because of the role played by medical laboratory scientists. But in Nigeria, it is underdeveloped. In Nigeria, there's effort every day to decimate the profession. When our forefathers started training for medical laboratory, I was speaking with one just 2 days ago.
Okay.
He's in his early 80s.
Wow.
And he said, once you passed what they called Part 1B in Nigeria, you will go abroad to go and do Part 2 and to become a medical laboratory scientist. And meanwhile, while you are studying for the Part 1, you were already placed then on grade level 6. So when you pass Part 1B, you are placed automatically on grade level 8. And you are given car, you are given accommodation. That was the pact. When you come back from passing the final professional exam in UK, you have a choice to stay back in UK and do a fellowship. And your salary will be running at home. That was the pact. So it started off well in Nigeria, but before the career path became very broad. For our colleagues who are abroad, they are doing well in the industry. They are doing, because now let me tell you the truth about medical lab science today. A medical laboratory scientist is not somebody who can work only in the hospital.
Okay.
By your training as a medical laboratory scientist, you can work in the hospital, doctor's office, laboratories in hospital. You can fit in and perfectly work in cosmetic industries. Oh yes. You can fit in and work in breweries. Oh yes.
Okay.
You can fit in and you have a career path in the water sector, in the environment, in agriculture. or what we call today livestock ministry.
Mm.
So our training
Mm.
is a rounded training
Mm.
that you are trained to know a little or
About
much
everything.
about everything.
Mm.
That is the training. In the course of my training, we still do it today, but very skeletal. I spent time, like in water board.
Oh.
Then it was Anambra State Water Works at Nkisi
Mm.
to follow through the processes of
So
water treatment
purification. Okay.
and quality control. So you see, you have a job there.
Yeah.
I spent some time then in Premier Breweries on it to follow through the process of brewing,
Oh.
the fermentation of sorghum,
Yeah.
quality testing,
Mm.
and very many other places that we were exposed to.
Mm.
So as a medical laboratory scientist, your scope of study is very wide.
Oh.
Today, the subspecialties in medical laboratory science is ever increasing globally.
Oh.
It was our colleagues that pioneered IVF in Nigeria. Oh, yes. Test tube babies. People like Mr. Manas. So the medical laboratory scientist is not just somebody who tests blood, stool, and urine. No, it's a lot more than that. It's a lot, way more than that. There's a medical laboratory scientist in New Zealand. He has not worked. I know him. He's a billionaire in dollar. He's not worked one day in any medical laboratory. What does he do? Rare horses, rare sheep, rare pigs for the production of serum, anti-serum, monoclonal antibody. And that's what he does. So it's a very diverse profession. But in Nigeria, they just think, oh, medical lab, go and test urine and shit. No. That is the least of what we are trained to do.
The very
minimum.
Anyway, you've had that. It's still a good career, and maybe not in Nigeria anyway. So take your physics, your chemistry, your biology, and then other sciences seriously, and do well. There are some universities that offer it now.
Oh, yes.
Apart from UNN and
no, today the course is available in virtually all universities in Nigeria. In our days, it was limited to some places, so you could move all the way from Imo State to go to Ibadan to go to study medical lab, and vice versa. You can move from the northern part of Nigeria to go to only UNN then. Today, it's everywhere. In fact, in the FCT, we have a medical lab science program in University of Abuja. We have a medical lab science program in Bayes University. We have a medical lab science program in Nile University. We have a medical lab science program in Veritas University. We have a medical lab science program in Ave Maria and very many other ones that are fledgling.
That's Abuja alone.
Just Abuja alone. So that is because it's the fastest selling healthcare profession across the globe. Forget the shenanigans in Nigeria. We will address it with time.
Hopefully. Anyway, that brings us to the end of this podcast. I want to thank you very much for coming. It's a huge honor to have someone like you on the Pinnacle podcast. The health is very important. Your health is very important. The health of everyone is important, and that's why we are taking it very seriously. I hope the government will also pay attention to our health and do the needful. It's not just the doctors, not the nurses, and the people who run these diagnostics too in the hospital. Everything ought to be taken very seriously. Everything that has beginning, it has ends. We are pulling the curtain on today's program. Don't forget to share this video to your loved ones so they understand the dangers of misdiagnosing malaria. And don't forget to watch the video. Of course, for you to get to this point, you've watched it to the end. But what I want to say is don't forget to also subscribe to our YouTube channel so you can continue to get content like this. My name remains Kelechi Nkwacha. Until we meet again, bye-bye for now.